Oh well, it's just another day in the office, starting off with a toric intraocular lens. Markings done, incisions done, continuous curvilinear capsular rhexis is also done. The hydrodissection being done. Hey, wait a second, did you notice something? No? Okay, let's go. Don't you think that the iris is abnormally flexible and mobile, and the pupil has become smaller, and the iris tissues try to get out through the incision site? Yes, you got it. It turns out to be a case of IFIS. Taking the weapons of rescue, the iris hooks from the armamentarium, Once the pupil is secured, the surgery continues with removal of the nucleus, removal of cortical matter, and implanting the toric intraocular lens. So what is IFIS? The Intraoperative Floppy iris syndrome is a clinical entity coined in 2005 by Dr. Chang and Dr. Campbell. It is characterized by loss of muscle tone in the iris that is shown as fluttering and bellowing of the iris stroma, progressive pupillary constriction, and marked tendency for the iris to prolapse towards the incision port. The main pathophysiology lies at the level of alpha-1 adrenergic receptors within the dilator pupillae when they are blocked, and they are said to be due to consumption of alpha-1 blockers like tamsulosin for patients with benign prostatic hyperplasia. Other factors could be age, diabetes, inadequate preoperative dilatation of the pupil. Now, we'll look into another case with a very good preoperative dilatation, incision, and rhexis went uneventful. We can observe there is mild pupillary constriction during hydrodissection. Phaco is proceeded in the case. The iris starts fluttering, and as you can see it tends to prolapse out of the side port incision. Once this is noticed, you hold the phaco procedure, come out, fill the anterior chamber with viscoelastics, and then try to put back the iris tissue with the help of an iris repositor. Once the iris is back in position, the surgery is carefully carried further and the intraocular lens is being implanted as planned. The iris lost so much tone as during visco-wash, the iris tissue is seen prolapsing out of the main port, which is then repositioned, and then the surgery is complete. So, to prevent this intraoperative floppy iris syndrome, one must get an adequate medical history, advise the patient to discontinue any medication related to this intraocular floppy iris syndrome, and also ensure adequate preoperative pupillary dilatation. Intraoperative management is done with the help of intracameral epinephrine, constructing an adequate and appropriate sized tunnel, getting the aid of oculoviscoelastic devices for mydriasis, and also ensuring the availability of pupil enlargement devices in the armamentarium. Eventually, it all depends on patient's education, the ophthalmologist's preparedness for possible modifications of their surgical technique, and the awareness of the urology community about the potential risk of these drugs.